some breakfast. We're ready. Let's start class early.
I'm so glad that test is over. It sucks so bad. Where'd you go for the last one?
I don't know. Yeah, but
Huh? It better be biscuits.
yeah. What?
Yeah. 2 hours later.
This looks pretty cool.
Hey there, Scrippy. My name's Patches.
Hey there.
I'll be taking pictures of your face today. First, I need to see your wristband. Let me see that real quick. Alrighty, Skippy, let's head on back. Follow me. Alright. Alright there, Skippy. We'll go ahead and lay on the table with your face down.
Okay. I was actually thinking about joining the program. Like, do you think you can walk me through what's going on and let me know what you're doing?
I guess. Oops, get on the
Okay.
table.
Alright. So, what are you doing first?
Well, the first thing you're going to do is you're going to get an 8x10 IR. Go ahead and put it in the bucket, which has a grid. You want to use a grid for these kind of x-rays. Next thing you want to do is make sure you got a 40-inch SID. That means distance.
Hey Patches, so what does this actually show?
Well, this projection shows fractures and inflammatory processes of the facial bones, the orbits, and the mandible.
Alright, that's pretty cool.
I know. I hate being asked questions.
So what do we do next, Patches?
Well, first thing you gotta do is you gotta put the head in a true lateral position. Now, in order to do that, you can oblique the body as much as needed in order to obtain a true lateral.
So, that hand, it was black. I really wanted to ask a question about it, but I didn't want to bring up any memories.
Now, a true lateral is when your mid-sagittal plane is parallel to the IR. And it's also whenever your IPL, which is your interpupillary line, is perpendicular to the IR. You also want to make sure that your CR is to the zygoma, which is the protuberance of the cheek. Now, how do you know if you're exactly lateral? Well, you got to align your mid-sagittal point to the IR. You got to make sure it's parallel. You also got to make sure that your IPL, which is your interpupillary line, is perpendicular to the IR, which is midway between the outer canthus and the EAM, which is your external acoustic meatus. I'm also going to put this sponge on your head to make sure that you don't get out of your true lateral position.
So are there any radiation protection measures that we could take?
Yeah, you're supposed to shield the patient. Let me go ahead and shield you.
Ow!
Shielding patients is for girls. And like I said, you want to make sure that the CR is at the zygoma, which is the protuberance of that cheek right there. And since you're faced on your right side, we're going to go ahead and put this right marker right there. All right, hold your breath. Okay.
In this projection, fractures and neoplastic inflammatory processes of the facial bones, orbits, and mandible are shown. The facial bone routine commonly includes only a single lateral, whereas the skull routine may include bilateral positions. Use an 8x10 IR, 70 to 80 kV range, and a small focal spot. For part positioning, you want the side of interest closest to the IR. Make sure the head is in a true lateral position and oblique the body as needed for patient's comfort. Align the mid-sagittal plane parallel to the IR and the interpupillary line perpendicular to the IR. Center the CR to the zygoma, which is the prominence of the cheek, or midway between the outer canthus and EAM.
Hello there! My name's Sai. I'm doing a parietal canthio projection, otherwise known as a water projection, on my friend here.
He's not really my friend.
We want to demonstrate foreign bodies in the eyeballs and the eye sockets, tripod and Lefort fractures as well. Before beginning, we want to make sure that our bucky is aligned to the tube, which it is not. So that's what we have to make sure the line is centered. We want to have a 40-inch SID, or distance, from the bucky to the tube. 38, oh, that's good. Next, we want to align the patients to the tube. And that's right there.
He was moving me around a lot. I got really dizzy.
Wanting the MML to be perpendicular, mid-sagittal plane aligned, CR exiting at the acanthion, which is right below the nasion. Make sure he's centered. We don't want to expose him twice. That would be bad, as it is his brain. And we all know what happens whenever we isolate tissues. It has lots of reactions inside. Everything looks good here. So in order to make sure the MML is perpendicular to the tube, we want to look and feel for his mastoid process eye. So I'm going to go ahead and just make sure he's nice and straight. And we also want to look at the orbital sockets, orbital roofs, to make sure that they're okay, so that no tilt is evident. Just a little. The patient may move, so we want to make sure his mid-sagittal plane is aligned center. The MML is perpendicular to the IR, which creates a 37-degree of OML to the IR. And after you've palpated the mastoid processes and the orbital margins, we are good to go. All we have to do is place the marker on the correct side of his anatomy, which will be the right, on this side. Making sure the tube is aligned. We don't want to make a double exposure, and we will proceed to exposing the patient. We also want to shield the patient. We want to make sure that their gonads are in perfect condition for reproduction. So we can place any sort of lead material as long as it's not obstructing the anatomy of interest.
That's right. You better shield me.
And then we will move on to exposing our patient. Hold your breath.
In this projection, fractures are mainly tripod and Lefort fractures, and neoplastic/inflammatory processes are shown. Foreign bodies in the eye also may be demonstrated on this image. You can use a 10x12 or 8x12 IR lengthwise, 70 to 80 kV range, a small focal spot, and a minimum SID of 40 inches. For part positioning, extend neck and adjust head until the MML is perpendicular to the plane of the IR. This will cause the OML to form a 37-degree angle with the table or bucky. The CR will exit at the acanthion, and make sure to suspend respiration upon exposure.
Similar to the Waters method is the modified Waters method, which is another parieto-acanthial projection. We're going to have the patient laying face down on the table, but as opposed to the MML for the Waters, we're going to have the LML aligned perpendicular to the IR, which is the lips meatal line. The patient may have moved, so we're going to have to ensure the same factors as before, which is mid-sagittal plane aligned, with the exit of the CR at the acanthion, same as before. Once the tube is aligned in position, mastoid processes have been felt, and orbital margins have been cleared for no tilt or rotation. We align the bucky with the tube CR. As you can see, this is an 8x10. Collimate to the appropriate size of interest, which in this case I'm going to keep it at an 8x8, just to make sure I have all the anatomy demonstrated. We're then going to mark the side of the anatomy. So this will be his right. once the MML is perpendicular to the IR, it'll create a 55-degree change of OML to the IR. That's it. We want to make sure to shield the patient again. Alright, sir, remain perfectly still, okay?
Okay.
Hold your breath.
In this projection, orbital fractures and neoplastic inflammatory processes are shown, and foreign bodies in the eye may also be demonstrated. Using the same technical factors, in this time, we adjust the head until the lips meatal line, LML, is perpendicular with the IR. This will cause the OML to be a 55-degree angle with the IR. CR will exit at the acanthion again, and don't forget to suspend inspiration. Hey there, Boo Boo. I'll be taking you to this back room to get some pictures of your face.
Boo Boo? Back room? Molly? Caliper? Clevis?
Can I see your wristband?
Yes, ma'am.
Hi, Clevis.
Well,
Hi.
what's up, girl?
Follow me?
Alright.
By the way, my name's Triquetra. Emphasis on the
Alright.
And I'm gonna have you lay face down on the table.
You got it.
And this projection is called PA axial. So the first things we is gonna do is put the SID to 40, at least 40. I set it to 42, 41. And then angle it 15 degrees. Caught at
Triquetra, am I supposed to lay this way?
face flat.
Alright.
And we want the OML to be perpendicular to the IR, so all the way flat. Ma.
Oh,
Ma.
oh damn.
There we go.
This hurts.
Next, we have to make sure the CR exit at the nasion. Right there. And the Bucky is aligned to get the picture. Now you just gotta make sure you put the marker right there in the light. Go shine a little light. This little light of mine.
No.
I'm gonna let it shine. And then gotta make sure to protect them family jewels.
Amen.
You want more babies?
That's right, Triquetra.
Triquetra? Now that tech. She was finer than a watermelon sitting outside of a KFC.
Lastly, gonna expose, so hold your breath and don't move. Alright. For this projection, using the same techniques, we're having the patient's nose and forehead rest against the tabletop, and you're going to tuck the chin, bringing the OML perpendicular to the IR. Make sure to align the mid-sagittal plane perpendicular to the IR to ensure no rotation or tilt of the head. The CR will be angled 15 degrees caudad to exit at the nasion. And if the area of interest is the orbital floors, we would use a 30-degree caudad angle to project the petrous ridges below the inferior orbital margin.
On a bad trip.
And I can't seem to find Molly, 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 Molly.
What?
Oh, start over. My bad. There we go. I'm just gonna like circle.
I got it. 3 seconds. Go back to normal. Go.
Oh, bloody hell. You scared me. Why hello there? I was gonna say, my name is Sai. Can I say that? Yeah. Alright.
In this projection,
Foreign bodies. Okay. This isn't gonna work. Not gonna work.
don't forget to put the marker.
I'm all set. On my friend Lad here. It's called the Waters projection. It's about the facial bones. Okay, that's it. Oh, my bad. Oh, hey. Oh, can we start over? I forgot my accent.